Good evening, everyone, and welcome to the second session of the monthly journal club in collaboration between the Egyptian Orthopedic Association and the OrthoBEMA. Today we have two interesting papers to be appraised by two eminent speakers. So Mohamed Shaya will take us through the fake trial about the VTE prophylaxis in foot and ankle cases. And the Hatim will be appraising a paper about the relation between vitamin C and CRPS in foot and ankle cases. So the main theme of the club this time is foot and ankle, and I hope you will you will enjoy the two papers and get a message from both of them. So Mohamed Shalan will be moderating this session, and Mohamed Shah will start with the first presentation. So if we can all put all your questions in the question and answer box or section, and we'll be having a discussion after every paper presentation, answering all your questions. So if we get all the cameras off except Mohamed Shayal, and Mohamed Shayal, please present your, put your camera on and start sharing your screen.
Yeah. Good evening, everybody. I'm Mohamed Shayal. I'm Orthopedic Registrar in South Wales. Today we are speaking about UK foot and ankle fate study. It's a very interesting multi-centric topic, prospective study of VTE prophylaxis supervised by Mr. Mangwani, one of the pioneers in the foot and ankle in the country, and I have a chance to work with him in Leicester University Hospital. So first of all, we are exploring VTE in the foot and ankle surgery through UK practice. This presentation criticizes the UK foot and ankle thromboembolism, highlighting methodology, key finding, clinical significance, what is the strength of this study, and how can make it more profound and take it to other step. So first of all, VTE complication, it's one of the serious complication in the orthopedic field, especially when it comes to lower limb surgery. Even with a simple cast, it can cause problem and it can cause major consequence. The main consequence of the VTE here, DVT and pulmonary embolism. DVT is simply the clots which can arise in the lower limb. Sometimes it's detached and make significant clots which transverse and tracking up to lung and cause major consequence, and sometimes it can cause this. Here we will speak how that correlated in foot and ankle surgery and how can we prevent these major consequences. And the objective of this study, first of all, we are studying the first 90 days post-op of the foot and ankle surgery, focusing and stressing on the frequency and severity of VTE in a certain patient group. We will speak about how it's differ and variable from trust to trust and from hospital to hospital, the VTE prophylaxis protocol, and even the risk assessment control, which is differ and varies from trust to trust. And we need to highlight and identify the risk factors, especially in a certain injury and a certain patient groups. Methodology here, the design of this.
Share your screen, Mohamed.
Sorry?
Share your screen. You haven't shared your screen.
It's not shared till now?
No.
Sorry, that was me. Yeah. Is it curable now?
Yeah.
Yes. So again, sorry for technical issue. Again here,
Make it full screen, Mohamed.
Full screen. I choose full screen.
No, from down. No. From the right side. From your presentation itself, PowerPoint.
Oh, yeah. Okay.
Yeah, perfect.
Yeah. So we speak about the complication of VTE and objective of the study about the first post-op 90 days and how it causes significant event of the VTE and consequence of the surgery itself. And we speak about how it's differ and variable from trust to trust to give a chemo thromboprophylaxis, and also the risk assessment differ from trust to trust. And we here we are studying the risk factor identification in a certain patient group and certain operations. And here, this is a multi-centric prospective national collaborative audit that mean many hospitals, included about 68 sites and hospitals through the UK. So that's why this is study is important to ensure that diverse geographical representation and participants. The inclusion criteria: all the patients who underwent foot and ankle surgery plus tendon Achilles rupture management, either conservative or surgical, from June to November 22. Only the excluded patient who have injection of chemoprophylaxis in theater room. And data collection here, we demographically we are speaking about the age, sex, ethnical background, medical history like comorbidity, previous VTE incidents, and also medical history. Procedural details include the time of surgery, type of the anesthesia, if the tourniquet being used or not, and how the duration of the tourniquet, thromboprophylaxis, how and for how long, and outcome if there is any patient had developed any kind of VTE or pulmonary embolism. We highlight them. The key finding of this study, it's about, fortunately, it's good result, as roughly we found 1 in 100 patients were affected in the first 20 days post-op. Mortality, this is rate less than 1%. It's about 0.03%, shows that the VTE complications seldom lead to this. And we found out there is no standard protocol across the UK hospitals. This means that every trust have their own policy in management of VTE, and also they have own risk assessment protocol and own chemoprophylaxis treatment. We found out about 30% of the patient received no chemoprophylaxis, and most of them got low molecular weight heparin, which been given to about 56% of the patient. Procedure impact on VTE, high risk group was noticed in Achilles tendon rupture. About 4% of VTE incidents were with non-operative treatment, while 2% of VTE incidents with surgical treatment of the tendon Achilles. Low risk being noticed in elective foot and ankle surgery. It's about 0.3%. And major risk factors. Does that make sense? The patient with high SA grade had high incidence of developing a VTE prophylaxis, and patient with previous episodes of VTE complication also been noted to have a high risk of VTE incidence. The interpretation of this result, this is finding have important implication. First of all, it's the result matching with being noticed in the previous research. This is add further support to understanding the VTE risk and make this paper a very strong position in support the evidence of incidence. Second, need of standardized protocol. Here we highlight that different protocol in giving prophylaxis of VTE pre-op, and also the risk assessment is differ. So this is urgently need to have evidence-based guideline to globalize the VTE in foot and ankle all over the NHS and UK. And we need to target prevention for a certain patient, especially who got Achilles tendon rupture, and also patient with high SA grade. And this has been noted to be the key risk factors in management of VTE in foot and ankle patient. Why this study is a strength is, first of all, as we said, that it's large number of patient representative sample as it's multi-centric. So this is the size and the geographical distribution of this hospital gives the strength of this study. Secondly, prospective design. The study minimized the chance of bias and gave a clearer picture of how the VTE developed after surgery. Comprehensive data collection. This is allow for a thorough analysis of potential influence on the VTE risk. So the main strengths here, large number, prospective, and also comprehensive data. Why this study is limited? First of all, some data been missed during like duration of preventive treatment. We noticed that when we study this paper, they didn't give a clear information about how long the chemoprophylaxis should be given pre-op or post-op to prevent the possibility of VTE risk. So we need something more clear about the duration of preventive treatment. Second, lack of risk assessment details. We don't know, based on what criteria, this patient being elaborated to have prophylactic VTE, chemical, low molecular weight, or other type of VTE prophylaxis. We don't have any clear answer about what is the risk assessment detail of this patient. Third limitation, it's observational nature of a study. It can only show association. Like it was very interesting that we found that the patient who received chemoprophylaxis for a long time before the surgery had higher risk of developing a VTE post-op, which it doesn't make sense as it's just observation. No clear justification of why this patient who get a VTE prophylaxis develop VTE after that. So what we need to do, first of all, this is a many area we need to work on it to make this as a global and make it in higher level of evidence-based. First of all, we need to arrange randomized controlled trial to compare variable methods of chemoprophylaxis, preventive chemoprophylaxis, medication-wise, duration, doses, and to see what is the outcome between all this medication, and that will give a clear evidence and support our results. Second and most important, development of risk assessment tools, and it should be globalized and widely spread all over the UK and NHS, which will make sense and make it the safe practice for every trust to deal with the VTE complication. Take-home message here: VTE is real but generally low-risk complication of foot and ankle surgery. Doctors need to be vigilant in assessment of VTE risk, particularly in patients with Achilles tendon rupture or with higher SA grade. Standardized protocol and guidelines for VTE prevention are necessary to reduce variation in practice and improve patient care. And UK FATE study is make a significant contribution to our understanding of VTE in a foot and ankle surgery. And also, this is to optimize the patient outcome. We need a further study for risk assessment tool and how long it should be. Thank you.
I can't see any question and answer question from the participant, but if I can ask Mohamed just one question regarding the Achilles tendon.
Yeah.
Is it acute rupture? For example, in our trust, the policy is for conservative management for all Achilles tendon rupture.
Yeah.
Or it is either acute rupture or failure of conservative management. Also, the age of the participant, we notice more than 16 years old. What about the high elderly people who have other high risk factor for VTE prophylaxis?
Yeah. So first of all, this study stress not on the way of the treatment. They globally speak about the outcome. They didn't specialize the outcome coming from the certain surgery over the other methods of treatment. They just mentioned that it's higher with Achilles tendon, higher with conservative management in Achilles tendon, but to elect some patient to have surgery or not, it's not for this study. But again, it's something related to long duration of embolization. If we treat the patient with conservative measurement for Achilles tendon, the chance of developing VTE is higher, as the long duration of immobilization again is needed. So I think this makes sense. But if we elect the surgical management, I think the duration of surgery will be less, which can cause at some point improvement in the outcome in terms of VTE post-op complication.
Sorry, I might be not clear. So, for example, if patient for conservative management of Achilles tendon rupture for like 6 to 8 weeks before starting mobilization,
yeah,
and then failed conservative management, and then go for surgical intervention, is it higher risk than patient who is going for surgical from the first day?
They didn't highlight that. They speak about either conservative, the outcome of conservative, but bridging from conservative to surgery, they didn't highlight anything about that. They just speak about either conservative, the outcome of the conservative, that 1, 2, 3, and the patient who treated surgical, the incidence of outcome is 1, 2, 3. But again, if you speak about the risk, I think the risk is higher, as this patient will go for longer duration of embolization, which is the most important contributing factor in developing VTE. You can imagine this patient being in cast for 6-8 weeks, and after that, he didn't got a full union or healing of tendo Achilles. Again, he will go for a surgery, and we will start to count from zero again, and he will be immobilized for some sort of 3-4 weeks. So if we say that 6-8 weeks of immobilization and the treatment conservative, again, and after that we will add the duration, it will be about now reaching about 10 or more than 12 week, plus the incidence of the surgery. So he will be the highest risk factors. I think Mr. Hashim can agree or disagree with my point, but it didn't mention clearly about the bridging between conservative to surgical management in this study.
So first of all, thank you, Mohamed, for the nice presentation and the good appraisal of the paper. So actually, I was a part of this trial, and we have, I don't remember the number exactly, but we have a very good share in the number of the patients. So answering your question, Mohamed Shalan, so this is an observational study. It hasn't interfered at all with any variables. It just have a look on the VTE prophylaxis in foot and ankle cases, including the Achilles, checking if the patient has been assessed or not. And if the patient hasn't been assessed, they just highlight that. And what VTE prophylaxis did the patient receive, and who is a patient who had a VTE event, and how this event was, and what was the commonest VTE prophylactic type of treatment the patient received. So it's just an observational study. So answering your question, this study came with few findings which were just subtle and few surprises. First of all, the few surprises is 32% of our patient does not receive a chemical thromboprophylaxis based on decision of the surgeon or the decision of the treating doctor. The second surprise is most of these patients doesn't have a formal assessment, which is according to the NICE guidelines, should for every patient coming with a foot and ankle injury should receive before he go in the hospital should receive formal VTE assessment to stratify the risk if this patient is at a VTE risk and how much risk is low risk, moderate risk, or high risk. And based on that, he should be starting on treatment. The difference, the non-surprise or the subtle changes which was covered is the Achilles one. We understand that the Achilles in itself as an injury is a risk for VTE. And why the VTE events is more in the non-operative versus the operative, the answer basically that both of them will weight bear day one. Both of them goes in an rehab protocol. We follow, most of UK follow the SMART protocol, the Swansea Morrison protocol for accelerated rehabilitation of the Achilles tendon injuries. So this patient stays for 2 weeks in an equinus cast, and from 2 weeks onward start to go in vacoped boot and start weight bearing. The difference between operating and repairing the tendon versus non-operative is with operating, the patient have the option to do a static contraction or what we call isometric contraction. This is our understanding why the VTE events is less in the surgical group. Both of them weight bear, but one of them has a tendon injury. There is no option for the muscle to do an isometric or static contraction, but with the repair, there is an option of static contraction or isometric contraction. But both of them has a higher risk of VTE prophylaxis rather than any other foot and ankle surgery. Most of our foot and ankle surgeries, they are now weight bearer from day one. Even the surgeries which doesn't allow weight bear, there is no increase in the VTE risk in them. So basically, with weight bearing, we understand from this study that the main factor contributing to VTE event is the weight bearing. Once your patient is rehabbing, is weight bearing, the risk of VTE is low. And the second thing we understand from this study that the event which will happen will happen. So by VTE prophylaxis, you save the low risk patient. the patient who is at high risk of having a VTE will have a VTE, whatever you do for him. This is the second point. But the good news is it's not fatal. So even the people who had the VTE event, according to the FIT trial, hasn't go to a mortality, it's all just a morbidity. So to sum up, VTE events in foot and ankle is very low. It's mainly in the Achilles tendon, especially on the non-operative group. What we came to know from this study that we have a defect in the standardized protocol. We don't have a clear protocol for VTE assessment and prophylaxis. Every trust and every hospital has its own way to do that. Number two, we don't have formal assessment for most of these patients. Number three, 30%, about a third of the patients didn't have a proper chemical VTE prophylaxis based on the caring consultant decision, which is not right, which needs standardization. If we come to the scientific point of it, so that the events already happened in the patient who will have an event, who patient who have a high risk of event, and as you can see, patient with high AC grading and patient who are medically prepared to have an VTE event. But on the other side, they were not fatal. So all of them were just causing some morbidity, not mortality. Explaining why the Achilles tendon cases has a higher VTE is the problem, as I told you, of the muscle contraction. That's why the people who had the surgery to repair the Achilles have the option to do an isometric contraction. VTE prophylaxis risk reduced by half the patient who had no operation. So, but VTE event or VTE risk with the Achilles is already well known. The study hasn't shown anything new. It's already well known that the Achilles injury in itself is a VTE risk. So it's a mainly observational study. The good thing, it was very multicentric. Nearly all the hospitals the UK has shared in it is a huge number of patients, and it doesn't give any explanation. It just gives observation, and this is one of the limitations in it. And we working in the BOFAS, in the British Orthopedic Foot and Ankle Society at the moment, to standardize a protocol for VTE assessment and VTE prophylaxis. And it should be out very, very soon. Definitely more robust evidence, more proper studies, randomized, prospective is needed to explain and to show a lot of variation, including the one you mentioned about the patient who was on VTE, on a conservative treatment for Achilles, then shifted to operative, and how this will increase the risk of VTE. But at the moment, we don't have that. All what we have is this multicentric prospective observational study, the VET trial. So the VET trial is a very good trial from my perspective. It gives, we now individually, before we have a protocol, all of us do a VTE assessment. The main problem of VTE assessment, when we went through the BOFAS to understand the problem, in our patients are a day case surgery. Day case patients. And the problem with the day case, there is no RMO, there is no juniors. Because there is no juniors, there was no formal VTE assessment. So the formal VTE assessment happens in the wards, either in the elective ward or in the trauma ward. The day case is just run by nurses. That's why the VTE assessment wasn't done properly. And it was one of the problems. And that's why from now onward, I'm not sure the other hospital, but for my hospital, you cannot discharge the patient from day surgery without doing a VTE assessment and prescribing the VTE prophylaxis. So it's a good observation study. It has shown a lot of positive findings, and it has shown us where is the defect and how can we correct it.
One thing, Mr. Hashim, I think most of the elite trusts in UK now have VTE nurses to look after the day case surgery and to prescribe the medication for all this kind of stuff. And also they should do the VTE risk assessment before giving this type of medication.
Yeah, so but it needs to be standardized. So yeah, all of this is just still individual proposals, but we're going to have a standardized protocol for assessment and prophylaxis. There is a question from Mary about if the increase in VTE instance has been observed after COVID or COVID vaccination. Yes, definitely. So after COVID vaccination, especially, the risk of VTE has increased. It hasn't been studied, frankly. So on top of my head, I don't have a clear evidence to answer this question. but definitely from personal observation, the patient with with COVID vaccination especially has a higher risk of having a VTE event than others. It hasn't been involved in this study especially, so we haven't commented on the COVID itself. But yeah, it definitely needs some study to answer this question with an evidence.
Yes, please, Mr. Hashim, can I have a comment,
yes,
please?
sure, Prof.
How are you?
I'm fine, thank you so much.
Many thanks to you and to Mr. Shalan for this nice presentation. Regarding these questions, I have two of my colleagues who had VTE after COVID vaccinations by 2 to 3 months, and it's reported to not to be immediately, but even late after COVID vaccination.
Yeah. So yeah, a lot of surprises inside the COVID box. So this black box hasn't been opened completely yet, but I'm aware of a lot of studies which is running around the COVID and COVID vaccination and their effect on the clinical practice. Ahmed Chalan is asking about elective foot and ankle surgeries. Who will need non-weight bearing? Will we be giving a chemical prophylaxis or not necessarily? Yeah, so Ahmed, that's a normal practice. So this is if the patient will be non-weight bearing, you'll be definitely giving a VTE prophylaxis. What this study has shown that if you give for elective foot and ankle surgery, if you give the proper VTE prophylaxis, incidence of events or VTE events are very low. So this is one of the good things that the risk has been increased with the Achilles only. But regarding the elective foot and ankle, the patient who is prepared, who is optimized, if risk of events with proper VTE prophylaxis is very low. So answering your question, the answer is yes. With elective foot and ankle surgery, you have to give, if they are non-weight bearing, you have to give a chemical prophylaxis. And I can assure you, according to the FATE trial, that the risk of having events or VTE events will be very low if your patient is just elective and well prepared.
And also, these questions highlight the need for standardized risk assessment before asking for every case by case if this patient need chemoprophylaxis or not. We need to have evidence-based standard risk assessment, not to study case by case, just to go for the standard. If this patient by the standard need chemoprophylaxis, we will give him. If this patient by the standard not needed, so we know that this patient can go without any VTE prophylaxis. So it's very important to highlight the need of standardized limitation of this study to have a standard protocol for chemoprophylaxis.
So I think there's one last question because we are beyond time. So Rafat is asking what type of prophylactic drug can we use? So as you have seen, the commonest drug used is low molecular weight heparin. We are not no one will be giving unfractionated heparin anymore. Still, there is a big question because we give a lot of our patients, especially the Achilles patient, is according to the trust policy. So my trust policy is in trauma patient, we give low molecular weight heparin. In elective situation, we give DOAC or direct oral anticoagulant, which is anti-factor 10. Some trusts, I know that they are giving antiplatelet, either one drug or dual antiplatelets, and they are doing well. This is one of the questions which the BOFAS protocol will answer. So we'll give you a standardized protocol, including what you should give as a chemical prophylaxis in trauma and in elective situation. But till the moment, according is different from trust to trust. I think the commonest practice is trauma gets a low molecular weight heparin, and elective get a DOAC or direct oral anticoagulant. Okay, we have to shift to the next interesting presentation. So another very common problem with the peripheral surgeries, including foot and ankle. Sorry. It's a very common with the wrist and foot and ankle surgeries is the CRPS or chronic regional pain syndrome. And Hatem will be taking us through a paper which correlating between the effect of vitamin C if you give vitamin C post-op with CRPS in foot and ankle surgeries. Please, Hatem.
Hello, everyone. Good evening. Thank you very much for giving me this chance
Hatem, yeah, we couldn't hear you.
But we still can't hear you, Hatem.
Hatem?
The sound is a little bit weak. I can hear you, but if you can raise your voice more.
No, I don't think we can hear you, Hatem. The problem if you're using headphones or something, just use the normal computer sound. So no, still there's a problem with the voice. So you can change your microphone, Hazim. So it's about the microphone. Hatem. Hatem, you're muted.
Is it any better now?
Yeah, it's much better. Yeah.
Okay. I'm using my phone, so Shalan will be sharing my presentation.
Yeah.
Apparently, I have some technical issues with my laptop, so sorry about that.
Just 1 second.
Can you hear me now? Can you hear me?
Yeah, we can hear you, Hatem. Just 1
Okay.
second. I will share the presentation.
Yes. All right. Okay. Thank you. Okay.
You can see screen now, Hatem?
Yeah. Okay. Sorry for the technical difficulties. This paper I'm going to present today is discussing the role of vitamin C in the prevention of complex regional pain syndrome after foot and ankle surgery. Here are the name of the authors, and myself, Hatem Hussein. I'm a senior clinical fellow in South End University Hospital. Next slide, please. And this paper was published in 2021 in the International Journal of Orthopedics. Next, please. Complex regional pain syndrome, or known as CRPS, is a serious post-operative complication that can develop after foot and ankle surgery, and it has significant impacts on the patient mobility and quality of life. There's a lot of studies that suggested that vitamin C supplementation might prevent CRPS. However, all of these studies were studied in contexts other than foot and ankle surgery. Given that foot surgery is common, assessing effective preventing measure is crucial. The incidence of CRPS in foot and ankle surgery is reported to be around 13%. However, only one study that has been performed exploring the role of vitamin C in foot and ankle surgery and prevention of CRPS. It's worth mentioning that the way vitamin C prevents CRPS is still unknown. However, it might be related to its antioxidant effect. Next, please. So the objective and aim of this study was to investigate the efficacy of vitamin C in preventing CRPS after foot and ankle surgery in a population of surgical patients, including trauma and elective surgeries. Next, please. So this was a monocentric prospective randomized controlled trial conducted between January 2018 and December 2019. It involved 329 patients who underwent different foot and ankle surgeries. And we had these patients randomized into two groups, one receiving 1 gram of vitamin C daily for 40 days post-operatively, and the other is the control group not receiving vitamin C. The incidence of the CRPS was then assessed using the Budapest criteria and corroborated by the three-phase bone scintigraphy at the follow-up visits. Next, please. Patients included, basically everyone had foot and ankle surgery, including ankle fractures, arthrodesis, ligament reconstructions, hallux disorders, as well as midfoot and hindfoot disorders, along with the removal of orthopedic implants. And that excluded pin removal surgeries and toenail surgeries. And exclusion patients who were excluded from the study, anyone who had a history of CRPS, or anyone who had a pre or post-operative infection, or fibromyalgia patients, or patients with psychiatric disorders, or any patient who were who was well known to have any addiction to any recreational drugs. Tourniquet was used in 91% of these surgeries, so that was not considered a discriminant factor for CRPS. Post-operative, next please. Post-operatively, all patients received the standard similar post-operative care concerning physiotherapy, analgesia, and VTE prophylaxis. And the control group, the patients had vitamin C, received daily 1 gram, as I mentioned earlier, for 40 days after the surgery. Next, please. And data was then collected using the medical records, including age, gender, BMI, history of diabetes, cardiopulmonary conditions, smoking, and alcohol consumption. It's worth mentioning that alcohol abuse was defined as consuming more than 6 units per day for men, or more than 4 units per day for women. Next, please. And this table is showing the patient characteristics and the operative data, and you can see here that the incidence of CRPS in vitamin C group was around 6% compared to 11.5% in the control group. And if you look down there, you can see that casting and alcohol both have eminent role or risk factor for developing CRPS. Next, please. So these has the results, as I mentioned. Vitamin C group CRPS occurred in 6% of patients compared to 11.5 in the control group. And accordingly, vitamin C intake is associated with a significantly reduced risk of CRPS. Alcoholism and the use of cast immobilization emerged as risk factors for developing CRPS. Next, please. Before running to conclusion, can you show us the next slide, please? And then we'll go back to conclusion. Yeah. So the strength points for this study, first, it was a randomized controlled study. The sample size was quite good. There was clear clinical endpoints and statistical analysis as well. However, some limitations as it's a single center study, and also due to the nature of vitamin C supplements, so we had a lack of blinding, and also the potential confounding factors related to lifestyle needs to be studied furthermore, like alcohol abuse or cast immobilization. Next, please. So I believe that further research could focus on exploring the optimal dosages and the treatment timelines for vitamin C in various contexts. Like, for example, patients with alcoholism are well known to be malnourished. And I think increasing the dose of vitamin C might be quite sensible. However, there's no robust evidence regarding the dosage. Can you go back to the conclusion slide, please? So the conclusion of that paper, that administering 1 gram of vitamin C for duration of 40 days following foot and ankle surgery is effective in significantly lowering the incidence of CRPS. And I believe that we can use this paper as a strong evidence for routine use of vitamin C as a preventive treatment or prophylactic treatment in the surgical population. Thank you for listening, and I'm open for any questions.
Thank you, Hassan. Hatem is very, very informative one, very nice appraisal. And to be honest, it's a very nice paper. It hasn't given a clear new message, but it has confirmed the message that the normal practice we're doing. CRPS is a very obscure point of practice for us and for hand surgeons. We don't understand the mechanism. We don't understand the pathophysiology. We don't understand how we prevent. I believe all the people on the floor are using vitamin C regularly to reduce the risk of CRPS. And I agree with you. We don't understand the basics behind that and how does it stop it. Even the theories explaining how the CRPS happens, so neurogenic theory, inflammatory theory, they are all just theoretical. There is no evidence on clear pathophysiology for CRPS to happen. So we don't have a clear answer for the question why CRPS is happening, and that's why we don't have a clear answer to the question how can we prevent it. From practice, we all agree that pragmatically vitamin C for 6 weeks, 1 gram, 500 milligram twice daily for 6 weeks, does the job for preventing CRPS or at least reducing the incidence. We don't have an explanation behind that. So I think the study has emphasized on a fact which is happening without clear evidence to make clear evidence behind the normal practice we're doing. The point of alcohol use and increased incidence with the CRPS with an alcoholic patient is totally understandable and expected. So basically, if it's neurogenic, either or inflammatory, both theories will be supported in alcoholic patient, because with alcoholic patient, they already neuropathic and they have some sort of neuritis, and this definitely make them more susceptible for CRPS. It needs more research, better quality research to run on it. But I think the message from the paper is very, very clear. It is not a new one, but it's definitely a very important message. And CRPS is one of the devastating problem all of us face in the practice, especially with periphery surgeries like foot and ankle and hand surgery. And yeah, we need more and more evidence coming to support the practice we are doing. So thank you so much, Hatem. And we open for any question. I think we already have 2 questions.
Yeah, the first one from Rafat. he asking if we can use vitamin C as a part of treatment of chronic regional pain syndrome.
That was not addressed in the paper. The paper was mainly about the prophylaxis in foot and ankle surgery. So that was not addressed as part of the paper.
So Rafa, basically, for yeah, we as I told you, we don't understand the physiology behind CRPS. So speaking about the treatment, to be honest, is one of the most painful situation you face in the clinic if a patient come to you back with a CRPS. But yeah, vitamin C definitely do a prophylaxis. So we nearly any patient which you feel that he's going through CRPS, especially with wrist injuries, and definitely foot and ankle surgeries. We start vitamin C twice, as I told you, 500 milligram twice a day for 6 weeks. At the end of the day, it's harmless. So vitamin C is just a natural vitamin. And the patient definitely gets some benefit. Treatment, there is a lot of options of treatment. I can promise you from now, all of them has no consistent results. They do sympathectomy, they do a lot. The patient get a lot of neuroleptics, but I promise you, especially with the wrist injury, this patient will be never happy. So definitely the paper speaks about prophylaxis and just showing evidence on the relation between vitamin C and prevention of CRPS. Answering the question about the treatment is a very difficult question to answer.
We have another question for Karan Hatem.
Yes. What's the other question? Sorry.
From Mohamed Khairi, he is asking if vitamin C is sufficient alone in preventing CRPS.
No, it's not. It's not sufficient alone, and it's not preventing. Again, it's decreasing the risk, but it's not preventing. Again, around 6% of the patients receiving vitamin C developed CRPS in that study. So apparently, so it's not sufficient to prevent it. It's not like a magic solution. No.
Yeah. So again, Mohamed, as I told you, we know that the patient on vitamin C is at lower risk of having CRPS. We don't know why, and we don't know. And this percentage is a huge percentage, from 4 to 11% is not a simple one. So it's more than double the patient who was protected from CRPS by a regular vitamin D intake, C intake. I'm sorry, but sufficient alone or not, we don't know how the CRPS happens, and that's why we don't have an answer for is it sufficient or not. All what we can assure you from the paper and from the practice, that vitamin C prevention or regular vitamin C intake definitely lowers the risk of having a CRPS in your patient, at least by 2 to 2.5% times than without vitamin C. I'm sure all of you deal with distal radial fractures, especially non-operative treated patients, and it's a devastating complication to have a patient with CRPS. You have to have a very good sense of suspicion, and once you feel that this patient going to CRPS, vitamin C has to be started immediately. I know a lot of surgeons who do it as a normal practice, but at least in my trust and the trust I have worked in, it's not a normal practice. But we definitely, once we feel that the patient is going to CRPS or at high risk, we start vitamin C for 6 weeks.
I think it was the last question.
Okay.
Yeah, perfect.
Thank you.
Yeah. Thank you, everyone.
Thanks, Mohamed, Shayal. Thanks, Hatem, for the two nice paper and the very good appraisal process for both of them. They definitely, both of them carries a message. Thanks, Mohamed Chalan, for moderating and organizing this. And sorry, guys, for the technical error, but I think it went, and the message has been delivered and received, well received. Feel free to comment if you have any comment. If you'll receive a feedback from mid-all. Please put all what you need in the feedback, what's good, what's bad. We're aiming to make this as a regular monthly journal club between Egyptian Orthopedic Association and the OrthoBEMA. I'm in the process of getting Royal College accreditation for this. So we needed to make it every time better than the one before. And this will not happen without you. It's aiming to you to give you an up-to-date knowledge with a very good, robust evidence and novel papers. So please, your feedback is the guide to us to how to improve this. So feel free to put what you feel in the feedback. all your comments will be taken on board, and all of them are valuable for us and very appreciated. Once you submit your feedback, you will receive a certificate. And I promise you, by next Journal Club, this certificate will be having some CPD from the Royal College of Surgeons. Professor Ashab?
Thank you so much. Thank you so much, my dear brother, Professor Mohamed Hashim, for this scientific knowledge and exchange of thoughts and knowledge between our dear colleagues from UK. And I wish you all the best, and I promise you the whole support of the Egyptian Orthopedic Association. Thank you so much.
Thanks, Professor Ashab, and for everyone, have a good New Year and a Merry Christmas if we will not be seeing you before that. In an hour, we will have our third lecture in the foot and ankle course. All of you are more than welcome to attend, and I promise you of a very good, fruitful lecture in one or three of the interesting topics in foot and ankle. See you all and have a good evening.